Dr. Alia Yamin. She is speaking on bacteriological spectrum of dacryocystitis and their antibiotic susceptibility pattern.
A very good afternoon to everybody. I am Dr. Alia Yamin and I will be presenting my paper on the bacteriological spectrum of dacryocystitis and their antibiotic susceptibility patterns. Dacryocystitis is inflammation of the lacrimal gland, which can be primary as idiopathic stenosis of the NLD or secondary to any trauma, tumor, infection, inflammation. So the microbiology of acute and chronic dacryocystitis infections may differ. It may shift over time, resulting in therapy failures. There can be geographical variation in terms of etiology, and the pattern and magnitude of antibacterial resistance may also differ from region to region. So if the treatment is started early, progression to chronicity, microbial resistance, and incidence of reoccurrence can be reduced with specific antibiotics to which the organisms are susceptible. It was a prospective observational-based, hospital-based study conducted from November 2019 to April 2021. First, the categorization of patients were done into acute and chronic on the basis of their signs and symptoms. The exclusion criteria for the study was children with congenital dacryocystitis, adolescents less than 20 years, encysted mucocele pyocele, common canalicular blockage, malignancy of sac, any maxillofacial trauma or surgery, any history of topical or systemic antibiotic in the past 1 month, recurrent cases and failed DCR. First, the specimen collection was done with the help of sterile cotton swab swiping against the lower conjunctiva, irrigation of the lacrimal drainage system, or applying pressure on the lacrimal system. And any spontaneous abscess pus was collected, or incision and drainage was done. 2 sterile swabs were taken. One was inoculated over the blood agar, chocolate agar, McConkey agar, and incubated overnight at 37 degrees Celsius, and then was taken for gram staining. And the swab 2 was directly taken for gram staining. This was followed by antibiotic susceptibility testing, which was done with Mueller-Hinton agar. A Kidbury-Bore disc diffusion technique was used, and the result was formulated as sensitive or resistant. For the methicillin-resistant Staphylococcus aureus and epidermidis, cefoxitin disc diffusion test was done, and the staphylococci, which was resistant to cefoxitin, was labeled as methicillin-resistant. The first 50 consecutive patients fulfilling the inclusion-exclusion criteria were enrolled in the study. So a total of 50 patients were taken, out of which 37 had chronic dacryocystitis and 13 had acute dacryocystitis. The age, 40 out of 50 patients were over 30 years of age, with a female predominance of total 32 patients. And maximum patients belonged to the upper lower class that constituted 46%. Comparing the culture positivity rate, a total of 35 patients out of the 50 had a culture positive discharge, and out of which 27, that is 77.2% of total, had a gram positive growth, and only 22.8% had a gram negative growth. Among the gram positive growth, Staphylococcus epidermidis was found in maximum cases, that is 28.6, and among the gram negative, Pseudomonas aeruginosa was the maximum, that is for 14.3%. And for the acute dacryocystitis group, the maximum number was found to be Staphylococcus aureus, followed by Pseudomonas aeruginosa, whereas for the chronic, maximum was found to be Staphylococcus epidermidis, followed by Streptococcus pneumoniae. For the methicillin-resistant group, total of 6 patients were found, out of which the incidence was more for the acute than the chronic dacryocystitis. So the overall antibiotic susceptibility for the gram-positive bacteria is as follows. It was seen that linezolid and vancomycin had a 100% sensitivity rate, whereas ofloxacin, levofloxacin, and ampicillin had the least, that was only 48.15%. For the gram-negative bacteria, amikacin had a 100% sensitivity rate and ofloxacin had 37.5. For the methicillin-resistant, it was only the vancomycin and linezolid that was 100% sensitive. So we can see RO represents the resistance to no drug, that is zero sensitivity. So none of the following organisms has had complete sensitivity, and around 40% had resistance to more than 5 drugs. So since dacryocystitis can be life-threatening, it can cause to orbital cellulitis, orbital abscess, meningitis, cavernous sinus thrombosis. Hence, that is why it is so important to treated properly. The female predominance was because of the smaller nasolacrimal canal diameter and hormonal variables. So, as the pattern of the predominant bacteria was seen in chronic and acute, it can be concluded that more virulent bacteria like Staph aureus are responsible for acute cases, and indolent like the epidermidis are for chronic. For the methicillin-resistant cases of the 6 patients, it was more seen in the acute dacryocystitis, as it comes out to be more aggressive in presentation with acute onset of symptoms. The possible explanation for the high susceptibility of amikacin in the cases of gram-negative is because it is not very frequently used in our community. So the broad-spectrum antimicrobial agents are commonly prescribed empirically to treat bacterial infections without definite diagnosis. Such practices are adding to the already existing natural antibiotic resistance mechanisms of bacteria and might be responsible for the relatively higher prevalence rate of resistance as in our current study. So the knowledge of the underlying etiology of dacryocystitis contributes to the choice of antimicrobial agent. Data on the regional distribution of the pathogens and their sensitivity helps in empirical antibiotic. Thank you.
In your opinion, which drug would be more feasible in case of chronic dacryocystitis?
So usually in our country, the most prescribed are the fluoroquinolones. But in my study, they are not 100% sensitive, and a higher resistance has been because of this, especially for ciprofloxacin followed by moxifloxacin, ofloxacin. So if the patient is coming to us without any prior use of antibiotics, we can go for a culture sensitivity. And on the basis of that, if it is gram-positive, as we saw, vancomycin and linezolid are the most 100% sensitive, and if it comes out to be gram-negative, we can go for amikacin.
So I mean, while on the basis of evidence, it does definitely, it sounds good, but I don't think in an OPD we can, if a patient comes with a lacrimal abscess, or an acute dacryocystitis, can we afford to wait for the sample to go into culture sensitivity for 48 hours and then initiate antibacterial or antibiotic
So
treatment?
in such cases, we can directly go for just the gram stain. That is why the 2 swabs were taken. One, we did go for the culture. The second was directly for the gram stain. Also, in such emergency cases, we can do that.
Right. So gram stain would just tell us if it is a gram positive or a gram negative organism.
Yes.
And in your gram positive organism, majority was Staph epidermidis,
Yes, sir.
which were 77% sensitive to amoxicillin clavulanic acid. So why can't we skip the gram staining and start on augmentin anyways?
Yes, sir, we can do
So
that.
what I meant to say is in terms of and also a lot of drugs that have been tested through to which we are seeing, say for example linezolid and amikacin, like say for example amikacin is not available orally, it has to be given only intravenously.
Yes, sir.
So how justified are we in starting IV treatment for acute dacryocystitis is another issue. But I think it's a good paper that gives us a good comprehensive spectrum of all organisms and sensitivity. So I think there's definitely some merit in the data. Amikacin is not available.
Amikacin.
And one more thing just to correct, I don't know what the other panelists think, but I don't think dacryocystitis is life-threatening.
No, it's not life-threatening.
If not treated, it is life-threatening for the oculoplastic cells.
Okay.
Thank you, Dr. Raj.
Thanks.
Next.